Okay, Zach.
Hello, everybody, and welcome to the weekly Independent Sage briefing. As ever, I'm Zach King. I'm going to be walking you through today's briefing. I'm now going to pass straight to Professor Christina Pagel, who's going to take us through the week in numbers. Christina, over to you.
Hi, everyone. Right, let me just share my screen. So, welcome to another briefing on the latest numbers on COVID-19 in the UK. And again, we've combined data from the government's daily figures, the Office of National Statistics, Public Health England, and the government's report on NHS Test and Trace. It's going to be a shorter briefing today to leave more time for questions. So I'm just going to cover the number of new deaths, the number of new infections, NHS test and trace results, and then kind of end about how what the numbers are saying about a push towards kind of zero COVID in the UK. This is the number of new deaths per day. It was 82 were recorded yesterday compared to 80 on the 2nd of July. The average daily deaths is coming down, which is good, but it's coming down slowly. We're still seeing 2 or 3 days a week with numbers well over 100. So we're really hoping that does start coming down a bit quicker soon. This is the new confirmed cases. So remember, to be a case, you have to have symptoms of COVID. You have to then ask and get tested for COVID, and then that test has to be positive. So this is people who've had a positive test. It's not anyone who's got a new infection. So people who never get a test aren't in this data. A week ago, the government changed how it was counting new cases. It removed the same person who'd had more than one positive test. That's a good thing. It means that it reduced the numbers a little, and you can't directly compare it to anything before the 2nd of July. So yesterday they had 642 new cases compared to 576 a week before. And you can see over the last week, it's actually been really, really level. There hasn't been any further decline. The R number is estimated at less than 1 in every nation, but it is highest in England. So I was saying that the new number of cases is people who've actually had a test, but we know that there are people who will get COVID and not get tested. So how many new infections are there a week? Because that's kind of really what you want to know. And we've been using 2 main ways of trying to get at this number. The first is from the Office of National Statistics. They're running a surveillance project where every few weeks they test about 30,000 people for COVID. So it doesn't depend on people coming forward with symptoms. So that's kind of one way of looking at it. And then the other way is from Cambridge University, their biostatistics unit. They have an epidemiological model of the infection, which feeds into the government's SAGE body. And that's a different way of estimating new infections. So last week, Cambridge and ONS were really similar at about 22,500 new cases a week. This week, they've completely diverged. So ONS has come down and Cambridge has gone up. And I suspect this is because we're actually quite low now in the number of infections in the UK, and so it's just really much harder to get an accurate estimate for this. However, although they disagree on the number of new infections, they do agree on one thing, and that's that they've stopped declining. So ONS, in their report that was published yesterday, have said, that actually since mid-May, the numbers of new infections have leveled off as far as they can tell. So although it was much higher in May, the last month or so has been around the same. And the Cambridge model, which is number of new infections per day, also in June has been pretty flat. So they're kind of agreeing that actually the numbers of new infections is level at the moment in the UK. So moving on to NHS test and trace and isolate. So what they're trying to do is find everybody with a new COVID infection, contact them, ask for their contacts, and then trace their contacts and ask their contacts to isolate. Now, previously, I've been kind of starting on from number of new infections, but because the numbers are so variable this week, I thought that it wasn't that useful a thing to do. So I'm starting from the number of cases. So this is a number of people who've had a test, who've been referred to NHS test, trace and isolate over the last 5 weeks. And so overall, it's just over 30,000 people have been referred. 76% of them have been reached by contact tracers, and just over 50% of them have provided at least one contact. And then of those contacts, there were almost 120,000 contacts for what are called complex cases. So these are cases that are outbreaks like in institutions, like hospitals or prisons, care homes, which are dealt with by local public health teams. And 99% of those contacts were reached and asked to isolate. There were over 50,000 contacts for non-complex cases. So that's people like you and me, if we got COVID and got tested and were referred to NHS test and trace. And only just about 53% of them, of those contacts were reached and asked to isolate. So you can see that it is a kind of a leaky system, that at every stage, you do kind of lose people and you lose contacts. Now, that's normal, but you want to reduce that leakage as much as possible, and we're still seeing a reasonable amount of leakage. We also know that not all people with infections are being found, and there's still no data on people isolating, and that really matters because it's the isolating of contacts that makes contact tracing work. That's how it's breaking the chain of transmission and stopping the virus spreading. Baroness Harding, who runs Test and Trace, was giving evidence to the House of Lords earlier this week. And she said that they've done some internal surveys of contacts, and people are saying it's actually really hard to isolate. It's hard for financial reasons because they lose money in their job. It's hard for personal and also emotional reasons. And that's why the support side of isolating is so important and something that we've emphasized repeatedly. But all we know is that it's still a bit leaky, and we still don't know on the finding, and we still don't know anything about the isolating. NHS test and trace has now been running for 5 weeks. So what I did is I looked at all the metrics they give in their weekly reports and just plotted them over time. And what matters isn't so much what each of these individual lines are. What matters is that they're not going up, right? So basically, since the beginning, NHS test and trace stayed around the same. There's not been any improvement. And that is concerning, because now what that means is that we have a test and trace system that is working. I mean, it's doing something, but it's not getting any better. And we do need it to get better. This is just kind of a geographical map of where the cases are currently. White means there were no cases in the previous week, so there are just 2 of those. Light blue is kind of quite a very low level. So the hotspots here are Leicester and surrounding area, and then the northwest of England. And then another way of thinking about where the cases are is looking at how many new infections are there, or new cases, per million population. And so this is a plot of where we are at the moment. This is new daily cases per million people in each nation averaged over the last week. England's at just over 9 per million. Wales, just over 5. Scotland and Northern Ireland are at 1 per million on average. And I've added the Republic of Ireland in, and they're between 1 and 2. And the reason I've added that in is because earlier this week, we kind of launched a call for trying to get to elimination of COVID in the UK and Ireland. 0 COVID is the target. And the idea is you can take advantage of the fact that together the UK and the Republic of Ireland are islands, and it's much easier to get down to elimination in that situation, like New Zealand has done. And we suggested that a good threshold for thinking about elimination is 1 case, 1 new daily case per million. And so if we look at that, we can see that Scotland and Northern Ireland are there, pretty much there already. Republic of Ireland is very close. England and Wales have further to go. But remember, we've already dropped tenfold since the peak in England. So it's just saying, can we get another tenfold drop and get down to 1 case per million? So just kind of to summarize, deaths and hospital admissions are declining, right? And that's a good thing. They're still going down. New infections are not declining. And that is concerning as we're opening up, because we're opening up in a situation where actually you're quite close to the threshold of presumably are being close to 1. NHS test and trace is working, but it's not working brilliantly. And what worries me about it is there's been no sign of improvement over the last 5 weeks on the metrics that they publish in their reports. And we still don't know how many cases are not being found, and we still don't know how many contacts are actually isolating. New infections are now at a low level in the UK. We are kind of reaching levels that you're seeing in France, Germany, Italy. They're close to elimination level in Scotland and Northern Ireland, which is really good news, but England is still 9 times too high for elimination. And the reason I think this matters is because elimination is the safest and the quickest way to open up your economy and avoid a new wave and new lockdowns. The lower the number of infections are, the fewer restrictions you need on your economy. And the safer it is to kind of start everything up again. And it also makes test and trace so much easier because there are just fewer new cases and fewer contacts that you have to trace. But what does opening up require? You need a low number of active infections. We are there now. We do have a low number of active infections. You need an excellent find, test, trace, isolate, and support infrastructure. It doesn't need to be world beating. It's a pandemic, it's not a competition, but it needs to be really good. And I don't think anyone could say that we have an excellent FTTIS system at the moment. And you need enough time between your phases of opening to assess impact. So basically, every time you open a new sector of your economy, you're adding risk to the population. And it takes maybe 3, 4, 5 weeks to see whether that's made a difference in the number of new infections. And the key thing is that the worse your FTTIS system is, the longer that gap has to be, because it takes you longer to work out whether there have been more infections. And so I'm just going to finish with an example of Germany and Israel. Both of them eased lockdown at a low level of active infections. But Israel did not have a good contact tracing system. In fact, they had an app that was struck down as illegal by their court and they had to withdraw it. And they also opened up every 2 weeks a new sector of the economy. And now they're experiencing quite a significant second surge in cases, and the government this week has admitted that it opened up too early and it's restarting its contact tracing system. And this is kind of where we are, and what I'm really hoping is that we're going to be closer to Germany than we are to Israel. But it's all about, how much better can we get out, find, test, trace, and isolate infrastructure, and can we slow down opening enough to make it safer for us? Thank you.
Thank you, Professor Pagel, for that really insightful presentation over the week's numbers. I think we're now going to pass over to Professor Reicher, who's going to do a little comparison between the Scottish and the English approach. I'll pass over to you, Professor Reicher.
Thanks. And thanks to Christina, as ever, for such clear figures. And as you saw, perhaps the clearest and the starkest of those figures are the differences in the different nations of the UK. So that in England, we're seeing figures hovering just under 10 new cases per million per day, and in Scotland and Northern Ireland hovering just above 1. So a tenfold different in incidence. And if you want to make it even more stark, well, over the last 4 days in England, 371 people died. In Scotland, it was 2. So we're seeing a huge difference. And the question is, why is there such a difference? Now, of course, there are some geographical factors. Scotland is less densely populated, it's more rural, it's possible to cut off the islands, and indeed closing off the ferries to the Western Isles has meant that nobody's died in the Western Isles. So there are certain natural advantages, if you like. But you just can't put it down just to that. There are a number of other factors, and they are factors of policy and there are factors of approach, which I think have made a major difference. And the first and the clearest is simply the difference between having a clear strategy of elimination and no clear strategy, or if there is a strategy of drift. Now, when we talk about an elimination strategy, let's be clear about what that means. It's not a guarantee that we'll get to zero, absolute zero, and stay there. We're in a connected world. We have borders. It would be very difficult to do that. But it's about not being satisfied with any level of infection and death. It's about not being satisfied with a plane load of people dying twice a week. It's about driving things so low that when you open things up, that people have confidence to go out. You don't get the situation we now have in England that you open things up and some people are going out, increasing the probability of infection, but not enough people are going out to regenerate the economy. So it's about a strategy which is good for public health, and as Christina said, is also good for the economy. So in Scotland, we've seen such a clear strategy, clearly articulated. Elimination is the aim, and all objectives are geared towards driving things as low as possible. In England, the UK government hasn't been clear about the strategy. We don't see any particular strategy. Some people talk about herd immunity by default, but nothing has been articulated at all. Instead, we see a series of ad hoc openings. We see a series of ad hoc relaxations before we have an adequate test and trace system. So I think it's better to characterize it as drift rather than a precise strategy. So one of the clearest differences between Scotland and England is the difference between an elimination strategy and just drift. The second thing, of course, are the policies which underpin that. Scotland has been more careful. It has been slower in opening up. It has been slower in terms of opening up the pubs, the restaurants, and so on. But that's not, again, it's not about trying to slow down the economic recovery. It's trying to drive the infections so low that when you do open things up, that things open up properly and fully. And also, it's about a matter of values. In Scotland, one of the clearest priorities is to make sure that when the schools go back, and they go back in Scotland in mid-August, on the 11th of August, my son will go back to school, then the infections are so low that we can reopen properly and we can reopen entirely. So a clear strategy, a slow, cautious, measured approach to reopening, and very clear public messaging around that. The messaging throughout has been not to go for quick, cheap headlines of Super Saturday or Independence Day, but to remind people we're in the midst of a deadly pandemic. We need to be cautious. We need to wear face masks. And indeed, from today, face masks will be compulsory in shops in Scotland. In so doing, not only stopping the spread of infection, but sending a very clear message to people we're still in the midst of a deadly pandemic. And that has led to confidence, and it had led to trust. If I had to say what is the starkest figure of all I've seen in the last week, it's that when you look at the figures for the UK government and for the UK Prime Minister, trust in handling the pandemic stands at minus 40 points. When you ask the same question in Scotland, trust in the First Minister in dealing with a pandemic, it's plus 60 points. And that confidence and that trust helps in the messaging, which delivers on the measures, which makes the strategy of elimination work. And that's what we see in the figures.
Thank you, Professor Reicher. Fascinating insight. I wonder if I could throw over to Professor Scally, who may not be expecting this, but he earlier this week wrote a really good paper that's on the Independent Sage website called A Better Way to Go. Professor Scally, perhaps a few words from you?
Yes. Yes, certainly, Zach. Thank you for that curveball. Yeah, we produced a paper this week which really was driven by the data, and the data that's been so eloquently explained both by Christina and by Steve in terms of the policy particularly in Scotland. But we are at a fork in the road here because, as has been explained in Scotland, in Northern Ireland, and in Wales to a lesser extent, there has been reasonably good control of the virus, and numbers are encouragingly low and heading in the right direction. England isn't in that position, and that tenfold difference in terms of new cases and tenfold difference between England and Scotland in deaths as well in recent times is very, very worrying. But as a way forward, what we're posing, and we note that there is no strategy that we can see for actually dealing with the virus. There is a strategy about dealing with the economy and relaxing restriction on economy and getting back to work, etc. But we cannot see the strategy for the virus. And our assessment of the situation is that we should not be throwing away the big advantage we have of several parts of the country being very nearly down to elimination, or certainly to close to, if not at very good control of the virus. We shouldn't be throwing away that advantage by loosening things up too much, too fast. And particularly, I think the key issue is one of international travel and taking advantage of that island status. But at the back of it all has to be the situation in England, and it has to be the lack of a really effective find, test, trace, contact, isolate, support system. And there clearly needs to be much more work on this. I think the other thing that's really important is that we do need to know, as we get flare-ups, and there will be flare-ups, there'll be flare-ups everywhere, but the important thing is that we are able to react in a timely fashion to identify the flare-ups, to know about it, and we won't know about that unless we do have the find, test, trace system working properly, and also to respond in a dynamic and effective way to curb those flare-ups. The fear being that if we don't, we will have multiple flare-ups, and they may actually coalesce into something even more serious as the autumn and the winter comes on. So I think we've set out our stall of a strategy, which is that we wish to see a zero COVID UK, in fact, a zero COVID Britain and Ireland, because it cannot be done without cooperation with the Republic of Ireland, which also has done extremely well. And if that is not to be the strategy, well, then we invite the UK government to set out what exactly its strategy is for COVID-19, because I think that strategy is not in place at the moment, and it really has to be. Thanks very much.
Thank you, Professor Scally. That's great insight once more. Now, we have lots of questions to get through today. So I'd like, if possible, everyone who's asking one, please keep it as brief as you can. And also to the Independent Sage panel, if you can try and keep your answers as concise as possible. So the first question comes from Mike Loveland. Mike, are you there? Are you with us?
Yes, I'm here.
Hello, Mike.
Can you hear me?
We can indeed.
Thank you. Well, thank you very much for inviting me to this presentation. At 77, I've been attending a great gym 5 days a week. This has kept me and my GP very happy. After 16 weeks of self-isolation, with regular home exercising, I would add, am I safer to stay as I am, or should I go back to the gym? And what are the issues that I should consider?
So Mike is 77. He is a regular gym goer, and he wants to know if it's safe for him to go back. And if so, what are the issues he should think about? Perhaps I can invite Professor Kunti to come in first on that, and then maybe Professor Pagel.
Thanks very much for that question. I don't know anything about your other health issues, but you already have two clear risk factors for severe COVID. It's age and being male. And so if you do get an infection, you're at much higher risk of getting severe disease and also succumbing to it. So our advice would be, if you are able to exercise at home or in your environment is in outside environment in parks, we would certainly recommend that, because most people can do that. It's only the people who are real heavy fitness fanatics who do need to go into a gym and there are many problems that we can discuss later on, but I'll keep it short for now in terms for this particular question.
Professor Pagel?
Hi, yeah, just to add to what Kamlesh was saying, is that it's become increasingly clear through the pandemic that indoor spaces are much, much riskier than outdoor spaces, particularly where the windows aren't open and there's kind of an enclosed ventilation system. And we also know it's riskier when people are breathing heavily, whether that's singing or shouting or exercising, as in the gym. The WHO also this week released an advisory saying they're not sure that the virus isn't airborne. They thought it wasn't, but now they're thinking it might be, particularly in indoor spaces. So I think all of that is saying, you know, if you can continue to work at home or outside, then I think that's definitely the safest thing to do.
Thank you, Professor Pagel. Can I push you a little bit further on that, Professor Pagel? Because I know you've done a couple of interviews on this. Do Independence Age, do you think that it is currently too soon to be opening gyms?
Yeah, I mean, it clearly is. It's only been 3 days since we opened bars and restaurants, which themselves are incredibly, you know, a lot of new risks to add. We have to wait, you know, 3, 4, 5 weeks to see what impact that has. And they're opening them up, you know, 2.5 weeks after, 3 weeks after.
Thank you, Professor Pagel. Professor Scally, one more point before we move on.
I completely agree with that. I think gyms are potentially difficult places, and we need to be very careful about that. But I'm also concerned about the message it's sending, opening up pubs, opening up gyms, and we still are not at a position where we're looking after our children properly and getting educational facilities open and getting good arrangements for. We should be, you know, busting a gut to try and help children and young people have a healthy, active summer out of doors and keep them at low risk. And where is the effort that's going into young people at the moment? I don't see it. And I think this government is prioritizing business, and that's important, and jobs are important, but we shouldn't be neglecting young people.
Thank you, Professor Scally. Before we move on, I think Professor Kunti wants to just make a point with some data, so I'll pass over to him.
Yeah, in terms of gyms, certainly I think that as an independent stage, we believe that this is too early to open the gyms, and there is a lot of data to back this up. So in China, they've done some work which shows that there was a lot of aerosol-generated virus within the environment. As Christina just said, it's a closed environment. There are other things to think about. Again, most of this is on modeling data. So if we sneeze, we generate aerosol up to 26 feet. If we cough, it's up to 16 feet. And these aerosols can stay in the air for anything from 3 to 14 hours. And we know we're not going to be staying that far away within the gym environment. The other issue is, okay, we can wear masks, we can work side by side. But again, we know in terms of when you're working in a gym, and my son works out in a gym, that you are going to be sweating, you are going to be coughing, you are going to be exhaling harder than what we talk. The harder the exhalation, the higher the volume and the higher the spread of it. And finally, once you've spread the virus in terms of aerosol droplets, we know it stays on steel, and many of the equipment is steel, stays on steel for 48 hours, onto plastics for 78 hours, and cardboards for 24 hours. So it will stay in the environment for longer as well, not just in the air.
Thank you, Professor Kunti. And Mike, I hope that's gone some way to answering your question.
Thank you.
I'd like to invite Ian Sample from The Guardian. Ian, are you with us?
I am. Can you hear me okay?
If you have a camera, do feel free to put it on.
You don't want to see my hair, trust me. I haven't managed to get it cut yet. I have a question about face masks. Does Independent Sage think that MPs and ministers should be wearing face coverings when they are serving people in Wagamamas or doing the rounds in shops and so on?
I see an immediate hand from Professor Costello. I'll pass to him first.
Yeah, I mean, I do think so. I think that was a terrible mistake, as it was going right back to the budget on March the 11th, when everyone was snuggled up closely in Parliament. And, you know, subsequently, half of our high command went down with COVID. It was a terrible message. and we should continue to emphasize the importance of indoor settings. A recent study in Hong Kong showed that all of the case clusters over their pandemic came from indoor settings, and most of them were from so-called mask-off settings, in other words, bars, restaurants, gyms. And in workplaces where people wore masks, the numbers of clusters and cases was much, much lower. So our message is wear masks indoors, wear masks in public places, and I think ministers should be setting a good example. And they're not doing that right now, particularly in England.
Thank you. I wonder if I can pass to Professor Michie to answer that.
Thank you. It's a complex issue, and Independent Sage is going to be publishing a report next week on this very topic, and our open meeting next week will discuss the topic and consult with people about our specific recommendations. But the combination of increasing evidence for aerosols as a transmission route, along with studies such as a natural experiment in Germany of different regions wearing face masks, and a study in a US ship comparing face mask wearers with those who aren't, is really tipping the balance in favour of wearing masks in indoor enclosed settings. And we're not a society who are used to wearing face masks or have done it in the past at a mass scale. So we need to get every single lever that we can to make this happen. And we've obviously had it made compulsory on transport. I'd like to see England following Scotland's example on buses, but that's not enough. We need a good mass education and persuasion and training campaign because people do need to wear the right kind of masks in the right way in order to make them maximally effective. I'll leave it there, but as I said, come next week and we'll go into this topic in more detail.
Thank you, Professor Michie. One more point from Dr. Hack, perhaps, before we move on.
Oh, yes. Well, just very quickly to add as well is that we should be doing exactly what Professor Kunti, Professor Michie and Professor Costello have suggested in relation to face masks, but also in relation to the FTTIS, the test tracing and isolate program in Leicester. Leicester is still in lockdown. It's as though everybody's forgotten that Leicester is in lockdown. The Chancellor of the Exchequer certainly forgot about Leicester businesses during his mini budget this week because there's absolutely nothing to support businesses. But the public information campaign and the masks, what should be mandatory to some extent, none of that is being applied to Leicester. And there is a real fear, if anybody goes to Leicester or if anybody hears anybody talking from Leicester, there is a real fear from Leicester that they're not going to come out of lockdown next week because essentially the government have walked away from Leicester.
And I think that takes us on to our next question, which I think is on the subject of Leicester. So I'm going to invite my colleague Kitty Teague. Do we have a question from Twitter on Leicester, Kitty?
Hi, Zach. Can you hear me?
We can.
Yeah, I got a question from Angela in Sussex. So she says, my mum lives in Leicester and I'm really worried about her. Is lockdown working? Do you have information about what is going on there? I'm very confused by the different reports. What do you make of what is going on there and is it working?
I wonder if I can invite Professor Kunti to answer this one first.
Well, certainly there's a lot of activity here. For example, yesterday they had a public meeting, and this is on live that people can access in 8 different languages of what people should be doing during this lockdown, which is a really welcome thing. And this is our public health consultant who arranged it, Ivan Brown. But in terms of it's on the ground, we know there's a lot more testing happening. My only worry is that we may be in a lockdown for longer than the 2 weeks. And the reason is the data came out yesterday that in Leicester we had rates of 117 per 100,000, and the closest rival was Barnsley at 17 per 100,000. We haven't got any data to say when will we come out of lockdown. What's the level at which any city would go into a lockdown or come out of lockdown? For example, Germany said 50 per 100,000. And that's the kind of data we need. But I think in terms of locally, they are doing a lot of work, probably, but not enough. The other issue is that in terms of what Christina just mentioned, find, test, trace, isolation, that doesn't seem to be happening as well, because it's still very centrally organized. So the local public health people do not have the data at very finite level, at postcode level, to say what are the contacts there are, how many have been contacted, how many have been isolated. That data is not available. I spoke to someone this morning and they don't have that data because it's still very centrally administered.
I wonder if I could pass to Dr. Hack to discuss a little bit further.
On top of that, the Leicester Mayor just released a detailed report has just come out, and perhaps we can share that later with you. Professor Michie shared it on her Twitter this morning. A detailed report has come out on Leicester, which is absolutely devastating, a real indictment of what's been going on in relation to Leicester and in the context of how the government have handled the pre-lockdown and during lockdown. Now, one of the issues, of course, has been, or one of the main issues has been the lack of Pillar 2 data, and that's the data about positive coronavirus cases in the community, outside, if you like, the NHS and the health sector. And that, of course, came extremely late. It came 11 days to Leicester after the government announced the breakdown. But what's worse, and what comes across in this report that the Mayor has shared, is that that Pillar 2 data is not disaggregated by ethnicity or workplace. And that's extraordinary, considering what we've heard about where the infections are in Leicester. They're in areas of extremely high ethnic minority populations, and also in relation to factories. Now, Leicester has a majority ethnic minority population. To give Pillar 2 data to Leicester without disaggregating it fully by ethnicity is wholly inadequate, and the government needs to return to its find, test, tracing and isolating data and make sure that every time it is collected and shared, that it's disaggregated fully by ethnicity.
Thank you, Dr. Hack. I see a hand from Professor Reicher, and then I think we'll move on. Professor Reicher, quick word on this one.
Yeah, I think language is very revealing. And the term lockdown is a term I dislike intensely, because lockdown is a punitive term. Lockdown is something you do in prisons. Lockdown suggests people have done something wrong and need to be punished. And that sort of attitude is what we are seeing in Leicester, rather than recognizing that you will have increases in infections predominantly amongst deprived population through no fault of their own, but because of the circumstances they're in. And the response is to support people. The response people is to find things early. It's to increase the testing capacity. And then it's to give the support that is necessary for people in order to be able to isolate themselves. And we see none of that. And therefore, lockdown isn't just the wrong word, it's the wrong policy. And I think we need to change both the word and the policy.
Thank you, Professor Reicher. I wonder if I can invite Susie Ring from Bloomberg to ask a question. Susie, are you with us?
I am. Can you hear me?
We can.
Yep. Yeah, I just wanted to get the panel's thoughts on the whole debate around airborne transmission. Obviously, there's been kind of calls this week for greater recognition of airborne transmission as research is growing, and the WHO's been fairly resistant, but came out with a paper yesterday acknowledging that it could be more of a dynamic. Clearly, the research, we need more research, but we're not necessarily going to get that research in time. So I just wondered what your thoughts are around putting in recommendations, given that we do seem to be seeing more evidence of this.
Thank you, Susie. I'm not seeing a hand, so I might volunteer Professor Pili for that one in that case.
Hi, Susie, and thanks for your question. In essence, what is new about considering airborne transmission is in effect, at a scientific level, the size of the particle that may carry the virus. And we do know, and the degree to which this happens clearly will impact somewhat on how infection is transmitted. Having said that, it is still the case that whether For instance, larger droplets are the source of viruses that then are held on surfaces, and you touch, and then you touch your mouth and face, versus airborne infection in the air. Whatever that is, it is still far more likely to be happening indoors. And so that goes along with our recommendations for as we open out our economy, that where increasing contact is within those indoor spaces, then of course all of the criteria such as face masks and others must be used, and that is still the way that we can prevent infection, whatever the degree to which airborne transmission is enhancing transmission over droplet spread. Thanks.
Thank you. And perhaps I can go to Dr. Oni and then Professor Costello.
Yes, it's just to reiterate the point that Professor Pillay made with this. I think it's important when we're thinking about weighing up the risks based on the evidence, that we remember, if we go back to first principles, that what we're trying to do is understand the exposure and transmission. So we are trying to understand the environment and the factors that contribute to the risk of exposure and contribute to the risk of transmission. And also we're trying to understand the individual behavior. So with every weighing up of, with all the weighing up of options, we know, for example, as Professor Pillay mentioned, with the aerosol transmission and the emerging evidence from that, the concern is that the smaller particles would stay up in the air for longer, and that would be most relevant and most important indoors because of that environment. And so in spaces where you have many people together, they're crowded and enclosed spaces with poor ventilation, and with different interactions, we are increasing the likelihood of exposure. And also to bear in mind that when we're thinking about the risk of transmission, we're also thinking about the duration of these interactions, the distance between people, and the different types of people coming together from different spaces, so not within the same households. So in engaging the risks of every activity, it's worth going back to those first principles to then say, well, how would that play out in terms of the environment, in terms of risk of exposure, and take it from there.
Thank you, Dr. Oni. Professor Costello, a word before we move on?
Yeah, just very quickly, the WHO put out a really excellent review of all the science of this about 2 or 3 days ago, I read it. And so it should be online. And if it isn't, I'll try and retweet it later. But it's very good if you're interested in the science. And clearly masks are related to the droplets, but ventilation is very much related to the kind of aerosol airborne transmission. And that's important to remember from a policy point of view. Clearly, droplets are thought scientifically to be more important, but there's growing evidence that airborne transmission does contribute.
Thank you, Professor Costello. I'd like to go now to Tamron Settle, who I believe is joining us from Oxfordshire. Tamron, there we go. Tamron.
Hi, nice to see you all. As my introduction, I'm Tamron and I'm in Oxfordshire. As you know, wedding ceremonies can now take place with no more than 30 people present. However, the tight restrictions on numbers, the need to social distance and the lack of any celebration after the ceremony means that this isn't something the vast majority of couples want for such a special day. There's been an absolute lack of government guidance. So what do you think would be the stages on a roadmap for the safe return of full wedding days, including the all-important celebrations such as dancing? What needs to happen to allow family and friends to celebrate together again? Thank you.
I wonder if I might go to Professor Michie on this one. She doesn't have a hand up, but I think she might have a good answer here.
Well, thank you for that very big question, because there's lots of things to take into account. And I think I really want to build on what Professor Oni said just now, that I think it's very much about thinking about the risk. Who is going to be coming to the wedding? what's the age profile of them? Where's it going to happen? Is the ceremony going to be indoors with lots of ventilation, and then the celebrations outdoor in a very well ventilated marquee? That would be much, much less risky than anything solidly indoors. And then how is the food and drink going to be served? So, for example, buffets would be out. Something I read about quite recently, which I thought was an excellent idea, actually for a wedding party, I think this happened, is that different coloured wristbands were available for people to select, with red being, I'm vulnerable, please keep a good distance from me, and green meaning, I'm fine with you giving me a hug. And I don't know how many colours there were in between, maybe 1, 2 or 3 colours in between that. So I think there's no overall situation where a mass gathering is going to be risk-free. So I think it will be down to whoever's hosting that mass gathering, and this is not just weddings, parties, other kinds of mass gatherings, as to what level of risk you as hosts and your guests feel comfortable with, and then going from the first principles, thinking about all the potential risks there might be and minimizing those. So I'm afraid there's not one overall answer to that. It's a very complex question, complex answer, and I think it's just trying to analyze it in that way.
Can I go to Professor Pagel, perhaps, for this one?
So I'm going to be even less positive than Susan about this. Like weddings are large events, people are drinking, people like each other and are close together. So there's going to be lots of physical contact. And we know that those kind of large events have been super spreading events across the world. Large parties, weddings, birthday parties. And very, very few countries, even the ones that have opened up the most, have opened up to gatherings of more than 30 or 50 people. So the safest way to get there is elimination. That's how you do it safely. We can drive down the numbers and then we can open up back to normal.
Professor Reicher, a final point before we move on?
I wanted to echo that last point because the question is a superb illustration of why the current drift strategy really helps nobody. I mean, if you open up too early, when there are high levels of infection, you open up in a way that really doesn't satisfy people. As you point out, you know, a wedding where you can't dance and a wedding where you can't hug people isn't really a wedding. And so it doesn't help to rush, and it doesn't help to then to have, you know, half-hearted weddings. What we need to do is to drive the infection down to levels where you can have a proper wedding. And that's why the strategy makes sense, both in terms of preserving lives, but also in terms of resuming ordinary life as soon as possible.
Thank you, Professor Reicher. I'd like to invite Leslie Riddick from the Scotsman and National. Leslie, are you with us? There we go.
Yep. Sorry, my head wasn't there. I'm sorry to drag you into what might be a political realm, but actually it's a public health realm as far as most of us are concerned in Scotland. And it's just getting back to this issue that may have abated for a while, but might resume actually if the disparity between infection rates continues on either side of the border. Is the Scottish Government right not to rule out border restrictions?
Might I go to Professor Scally on this one?
Yes, a very good question. And I think you only have to look, for example, at the way in which individual states in the US are taking different approaches, or in Australia. And the state of Victoria now virtually cut off from the rest of the country to try and deal with the outbreak in Victoria. Of course, borders are very important. These are not political questions. These are public health questions, as you correctly said. And restrictions on movement across borders on the grounds of public health is an entirely appropriate response. And it is something that should absolutely be considered. And in a sense, if you've got to have a border, I'd really like to have a land border like Scotland's. It's only 96 miles long. It has none of the complications of the 310-mile-long land border in Ireland. That is really a problem in Ireland as well. So we've got to get past this thinking of these borders as being some sort of major political problem. They're a public health problem. And it comes down to the determination of governments, both in Whitehall and across the rest of the UK, to do what they need to do about the virus, and that's get it down as near as possible to zero, so that we can have a normal life. And I applaud what Scotland is doing. And of course, they're absolutely right. We should remember how the virus got to these shores. It came from holiday makers coming back largely from Italy, and at the beginning. And if we're not careful, it'll be airlines that will be reintroducing the virus to Scotland, to Ireland, and to the north of Ireland, just at the time where, after fantastic sacrifice and hard work, we've got it very nearly down to zero.
Thank you, Professor Scally. I think that was a pretty fulsome answer, but does anyone else have anything to add on that? No. Okay. Do we have Helen Doyle here? Helen, I think I saw you. Are you still in the room?
Oh, hello. I'm just checking if you can hear me. I joined too late.
We can hear you, Helen. Go ahead.
Perfect. I guess I caught the very end of a question from Mike. I think it was at the beginning regarding the safety of gyms, and I obviously wouldn't want anyone to repeat anything they have said already. Is regarding the air conditioning units. I've worked in gyms for nearly 20 years, and for the first 12, I was in a high density populated gym, as it were, and every year I had several chest infections and couldn't put it down to what it was. After I left working in that environment, I no longer had chest infections and recurrent bronchitis. Personally, I put it down to the aircon unit. So I was wondering, from in this context of reopening gyms, it's obviously too early, as was discussed. Would there be some recommendation of some sort of assessment of aircon units in public places, specifically gyms with the higher respiration rate, as part of the opening assessment? Because I think that would be vitally important. As my own experience, many of the units that I saw were very filthy. So I guess that is quite a big concern, just from my own experience of working in them environments.
Thank you, Helen. Professor Pagel has something on this, I think.
Yeah, just to say that is a kind of ongoing area of research. I know that, as you know, that some of the southern US states are really surging right now: Texas, Arizona, Florida, California, all states that very heavily use air conditioning. And I do think researchers are now looking into the role air conditioning might play. I don't know if Dean has anything to add to that, though.
Professor Pillay, anything to add there?
Yes, thanks. Well, briefly, of course, air conditioning is an important component, but there is air conditioning that recirculates the same air. And there's air conditioning that actually ensures there's fresh air coming in, number one. So it's the devil is in the detail here, and I think there probably needs to be some assessment of precisely what we mean by air conditioning. The best air conditioning is, of course, a through breeze with open windows, because that actually just takes the air that may contain viruses out of the environment. The second issue is just to remember that air conditioning units are different. Some of them, in fact, have particulate filters in them. Now, it's very difficult to develop filters and use filters that will filter out things as small as viruses, depends on the size of the droplet, etc., etc. But this then gets into this is part of the detail of air conditioning, and I strongly suggest that we open that debate as to the sort of air conditioning which will really maximize the limit of transmission of the virus.
Thank you, Professor Pillay. Can I go to Professor Kunti and then a quick point from Professor Michie before we move on?
I think again, this comes down to how much evidence do we have, and this is where we really need the evidence base. Everyone who has an expertise in this field needs to get together and say, this is what we have the evidence these are the recommendations. I haven't seen this yet. So if we look at the National Health Service, we take that as an environment. We need to do an assessment of the workforce and the workplace. So, and I think in anything you're opening up, you need to make an assessment. You need to look at the environment. It's a safe environment. So the issue about the air conditioning, we don't know the evidence. There will be people who know the evidence. They need to look at that. Is the environment clean enough? How often are they going to clean it? What's the minimum size of the number of people who need to go in there? How often are they going to clean overnight after each individuals that use the gyms? All of that needs to take into place. I don't see any recommendations regarding that. And secondly, who do you allow into the gym? This is the individual assessment. There are people who are at higher risk, age, male, comorbidities, etc. So again, there needs to be certain criteria to say these are the people we should really be allowing or encouraging, and these people should be we should be discouraging.
Thank you, Professor Kunti. And Professor Michie.
Yeah, I wanted to raise the more general issue about who's going to really assess and sign off the safety of gyms, of pubs, of wherever is going to be hairdressers, wherever is going to be opened up. So we know, for example, that 4 out of 5 people on public transport where it's mandated are wearing face coverings. 1 in 5 aren't. But whose job is it to oversee that and do anything about it? It doesn't appear to me to be thought through. And if we want to look at scientific evidence translating into policy and practice to look after population health, we do need to pay attention to the whole process of how guidance is implemented and to ensure that systems are set up to check so that when people do go to a gym or a restaurant or a pub, if they do go, they have some idea that it's going to meet certain minimum standards of safety. And I'm just not aware that those are in place satisfactorily.
Thank you, Professor Michie. A final comment from Dr. Oni on this one before we move on.
Yes, just to build up on that point, the other thing we need to be doing more of is assessing the systems that we already have in place, and seeing, and if the critical issue is that they're under-resourced, then putting in the resources that way. You know, if we're talking about who is assessing the air conditioning system in gyms, well, we have a very well-established system of environmental health officers. For example, if you have a new restaurant opening, there is a system in place for someone to check that it meets the health standards before that can open. So those things have been playing out. If they weren't in operation, we'd have a lot more outbreaks of food poisoning and that sort of thing. So they've been working out in the background all the time in the community. They're critically under-resourced, but if the issue is that these systems are in place but they're under-resourced, then let's look at strengthening those rather than necessarily as neglecting them and pretending as if they don't exist.
Absolutely.
Thank you, Dr. Oni. I'd like to try and go to Gwyn, who's joining us from East Sussex, I think. Gwyn, are you with us?
Hi.
Hello.
Hello. My question, hopefully you can see me, my question is more really about ICE Independent Sage itself, I suppose. I've been following it for the last couple of months. I was quite excited initially when Independent Sage came out. But the general sentiment of what I've seen is that at every step of the way of this loosening is that there's been a general negative, slightly doom and gloom, that every time we loosen things, we're going to see an increase in cases. It's all going to get terribly worse. And since the 10th of May, we've had beaches, we've had all the people on the beaches, we've had the protests, we've had the underground raves, more schools have opened, and yet we haven't really seen an increase in cases. And although given the vagaries of testing, that might not be the best measure. But more importantly, we don't seem to be seeing an increase in hospitalizations and deaths. In fact, quite the opposite. So I've got this general negative feeling coming out, and yet it hasn't been getting worse. And I wonder what you think about that. I don't know whether that's an unfair characterization. I've been following stuff on Twitter from Professor Scally and Professor Costello and Sir David, and that's the feeling I've got. I hope it's not an unfair characterization, but I just wondered how you respond to that, what you've learned from it maybe, and what you can usefully apply going forward. And if I could be cheeky, I'm just wondering what tangible impact independent stage is having. Thank you.
So quite a bit of ground to cover there. Why don't I come to Sir David first to sort of give it a general overview of what we're doing, why we're here, and perhaps some of the achievements, and then we'll go to some others for some of the more detailed parts.
Thank you, Zach. Gwyn, you're asking a very important series of questions. It's not just one question. Independent Sage is present here and now, showing how we operate in the open, transparent. We are there with a tremendous series of experts in front of you right now. And we are the only group that are open to criticism, to questions, etc., from the public and from the media. All of my group in front of you here, this group, have been on the media very frequently. So there's a real hunger from the media for this sort of thing. Why are they turning to us? It's because none of the others are allowed or available to go freely onto the media. So this is a major part of our exercise. But the second is, of course, we always take the epidemic where it is and then try to give the best possible advice for going forward in time. Now, Independent Sage at this point believes we're at the fork in the road, to quote Professor Scally, and that fork is critical at this point in time. We saw the data from Israel compared with the data from, let's say, Germany, where the second spike is much bigger than the first, and the follow through from that is a major new outbreak, and what that is very, very likely to do is yield many more deaths, and of course much greater demand back on the National Health Service. So at all costs, we've got to avoid taking that risk. Now, I've got colleagues here who can answer your very important questions about the number of deaths and the level of the disease in the country. You've heard, I hope, Christina's presentation this morning, but I'm going to leave it to my expert colleagues to take the other questions.
I wonder at that point, maybe I'll bring in Professor Pagel to comment further.
Sure. I mean, I think that with deaths and hospitalizations, they are what's called a lagging indicator. So people who died this week will most likely have been infected in early June. And hospitalizations are like 2 to 3 weeks after infection. So yes, they're coming down, but the stabilization that we've seen in numbers of new infections won't have gone into that yet. And the other thing is that there is a change now. I think Gabriel Scally can say more about this, but say in Ireland, you're seeing that now the new infections tend to be in younger people. And so it is, the new infections tend to be in people who are less likely to need hospital and to get very sick. So that kind of combination is affecting that. But of course, the more people are infected, it's very easy to then get the kind of vulnerable people reinfected.
Thank you. I wonder if I can see hands from virtually everybody, so we'll get through as many as we can. Can I go through to Professor Costello first, and then we'll go to Professor Reicher?
I don't think we've been totally negative. I think we argued on June the 1st not to open schools, but to do it on June the 15th. And a month later, we haven't seen schools open, we've seen pubs open. And I think that's outrageous. The other thing that we've largely focused on is find, test, trace, isolate, and the data that Christina presents. If we'd followed this advice from way, way back, we would have had far fewer hospitalizations and deaths, and we wouldn't have a lockdown in Leicester. And in fact, we're still skeptical about whether you actually need a lockdown in Leicester in the way that it's been done. So I don't think it's quite true. I mean, we are critical of anything that infringes public health rules. And sadly, quite a few of the things that the government have done have been to do that, infringe public health guidance or good public health practice.
Professor Reicher, something to add on that?
I mean, I think it is true that there has been an attempt from some quarters to portray us as a rather miserable, killjoy and moany lot. I mean, in part, that's a compliment because it shows that our arguments are having some effect, and therefore there's a response. But we're not, first of all, we're not a miserable lot. It's not that we don't want to dance at weddings. We want weddings where you can dance by actually dealing with the infection, as we discussed earlier. And as for being moany, well, if there are things, as Anthony said, that undermine public health, we will be critical. But if there are things that will help public health, we will praise them. And that's precisely what we discussed, in a sense, at the top of this meeting, where we talked about the positive practices we've seen in Northern Ireland and Scotland, which we praise, and other practices which have been less advantageous for public health. And in terms of things getting better, absolutely true. It would be appalling if we hadn't got better from lockdown, but we're still not doing well enough. We're still seeing about 1,000 deaths every week. We're still seeing the equivalent of 2 jumbo jets worth of people being killed every week, and it's avoidable. And not to speak out about that, and not to offer an alternative to that, which we try and do. We don't just criticize, we offer alternatives. That, to me, would be entirely irresponsible. So our aim is to be constructive because, okay, things are getting better, but we could still be doing so much better than we actually are.
Dr. Hack, something to add there?
Yes, I mean, you can't gimmick your way out of this pandemic. You know, our game plan is zero COVID, and our game plan is to save as many lives as possible. And this is about life and death. And you know, I don't mean to be trite, but the entire game plan should be about saving as many lives as possible. And the reason we have been transparent and the reason we have been somewhat critical is because the government strategy is incredibly vague. We don't know what the government strategy is. We don't know what the government's game plan is. And it certainly doesn't seem to be a safety plan. And given the amount of evidence we now have about who's vulnerable, which areas are vulnerable, and how disadvantaged groups and disadvantaged areas are vulnerable, there is no protection. So I think we will carry on as we are because our game plan and our aim is zero COVID.
Thank you, Dr. Hack. Still lots of hands. I'm going to go to Professor Pillai first.
I'd just say thank Gwyn for that comment and set of questions. And it's important that we, as any group, are subject to critical review from outside the public as well as inside ourselves. Just a couple of comments. First of all, I don't think our messaging is really very controversial. I point to the CMO, Chris Whitty, saying at the time that Boris Johnson announced the end of the lockdown, his immense concern that we do this incredibly carefully. And I think we're just supporting that view. What we are doing is adding a little bit of meat on the bones. You know, when there's discussion about face masks, well, how should that be done? When pubs are opening, how should that be done? With test and trace, for instance, and as Christina mentioned earlier, Baroness Dido Harding mentioned in the Select Committee earlier this week that in fact it was a particular worry about not being able to keep people who are asked to isolate isolated. And that speaks to the issues we've been talking about for some time in our documents about support for those people isolating. So I don't think there's a contradiction here. I think we're just trying to support and help that process of being very careful. And my last comment would be, well, from your perspective, Gwyn, you know, what would you want us to do that we're not doing at the moment in terms of supporting moving to the end of the pandemic? Thank you.
So let me go to Dr. Oni, if you still wanted to come in.
Yes, it was just a minor but important point that when we talk about cases and we talk about deaths, and Professor Pagel has given some explanation about those differences, but there's something in between missing, which is morbidity and the illness. So this is a new disease, and we understand very little about what the complications and what the long-term consequences of having even mild infections are. So there's something, perhaps the urgency with which we're addressing and saying, well, we don't think it's enough to not have a strategy to go below zero, is we don't think it's sufficient to say, well, okay, there's fewer people dying, so it's okay to have people infected. Because we don't actually understand and we're starting to see potential consequences on the heart, on the brain, and on different organs, just even in people with mild disease. So I think it's really important that sense of urgency and to drive the number of cases down beyond just talking about deaths is something that is that we should keep talking about.
Thank you, Dr. Oni. I'd like to go to Sir David and then finally back to Professor Pagel, if that's okay. Sir David, did you have a word you wanted to say?
Yeah, just very quickly, I wanted to say, while we are bearing in mind the health and fatality rate, etc., we're also bearing in mind the economy of the country. So we do have an equal concern in the state of the economy. And quite clearly, the quicker any country gets over an outbreak of this kind, gets over means towards zero COVID, the more quickly the whole economy can be opened up more safely. Now, we're simply not achieving that. We are emerging as the worst country in Europe in terms of the economic hit, and one of the worst in the world. So I think we have an equal concern with the economy and the health of the nation, and they both pull in the same direction. We do not see a contradiction.
Thank you, Sir David. I'd like to go to Professor Pagel finally, and then we'll move on.
I just wanted to touch on the kind of negativity thing. I have no desire to be negative. I'm honestly quite desperate for the government to do a good job on this. I believe that this is a time when, you know, countries should come together. But when there's something like test, trace and isolate, which everyone knows is the cornerstone for how you cope with a pandemic like this, and we can see that it's not working from the government's own reports, like, we have to talk about it because it has to get better. You know, the cases have come down, deaths are falling, hospitalizations are falling. That is unequivocally a good thing. But we have to plan for a second wave, because that's how you save lives. We can't just assume that everything's fine. I mean, that's kind of this kind of drifting strategy. We have to keep fighting to get to elimination.
Thank you, Professor Pagel. And I think, Gwyn, thank you for that question, which has clearly elicited quite the response. And that feels like a good moment to wrap up today's session. Let me apologise to all of those in here who haven't had a chance to ask a question. Once again, time has got away from us. It just falls on me once again to thank all of those who've joined us on Twitter and YouTube, and who will be catching up later. So thank you so much, and goodbye for now.